Good afternoon, and welcome all to Naples United Church of Christ. My name is Mark Williams, and I serve as the senior minister here. And on behalf of the congregation, a warm welcome to any and all of our parishioners, as well as those from the wider community. Some days ago, my son turned 13, and on his birthday, he asked Mom and Dad, what was the name of the hospital where I was born? And we responded to Nolan, you were born at Baptist Hospital in downtown Columbia, South Carolina. And 13-year-old then responded back, Dad, that's odd. Why would a hospital be named after a church? Well, with many here with a background in healthcare, you can remember the hospital boom that happened back in the 1950s, where many churches envisioned construction of hospitals, Baptist Hospital, Methodist Hospital, Presbyterian Hospital, Sisters of Charity, Catholic Hospital. And it may not be the 1950s. However, my sense is that the church is still in the business of promoting help and healing to the wider community. After all, this was Christ's business, to help and to heal. And on behalf of Naples UCC and the Naples UCC Justice Committee, it is in keeping with that mission and with that spirit of helping and healing that we host this event today. What a joy it now is to turn it over to Dr. Bob Nordland, who has been a member of Naples UCC for many, many years. He currently serves on our Board of Mission and Outreach as a previous stewardships chair, and recently worked with our Aging Well series. Bob, welcome, and will you all join me in welcoming him?
Well, thank you very, very much, Pastor Mark. I know it's a really busy time right now, and we can't thank you enough for taking the time to support this worthwhile project. And speaking of that, this is really a project that got started through the Justice Committee, and here comes the chair of it right now, Jennifer Walker, and our guest speakers, and we're bringing them to the stage right now. What was interesting when Jen asked if I would be willing to moderate this discussion, and it's actually going to be, we're just talking about this, a little more discussion than just lectures and didactic speakers, but we are going to try and divide this up today to have each speaker give kind of their presentation without interruption of questions and so on at that time, and we'll go through the two of them, but we have handed out pieces of paper or notes and so on, or ways that you can send to us questions that you'll have, and kind of the sooner we get them or identify who they're for, or if they're for both people, that'll really help us in going through those questions when we get to the question and answer time at the very end. But another thing that was interesting when Jen asked me about doing this is that I thought, wait a minute now, who are the speakers going to be? Well, it turned out to be right at home here with the two speakers that are here, because when we moved here, my wife and I, in 2010, leaving Minnesota and the cold to come down here to the warmth. But anyway, today maybe not so much. But in any case, I also wanted to volunteer and be involved as best I could. And the very first thing I found out is that NCH has had a tremendous track record in helping retirees, keeping up their licensure and their certification and so on, so we could volunteer. And it was the first place I started to go, to the tumor conferences, the grand rounds, all the others, to keep up my licensure with many, many other doctors. There are a number of them that are here right now that have volunteered. And where did it end up that we volunteered? Well, at least a number of us anyway were at the Senior Friendship Clinic. So that takes me from Paul Hiltz over to Jamie, because Jamie represents the healthcare network. And it was actually that last stop of our clinic with the Senior Friendship Clinic that had sold their own buildings and so on, and we merged in for the last few years anyway with the healthcare network, and it was a nice, beautiful building that's still there and going well right across from the government building on Airport Pulling. So I had a direct connection, and I thank you for that past experience, and a lot of us do, but we also now are facing a crisis in healthcare, and the reason we're really having this program is to look at it from different angles. It's not going to be all easy, but it's going to be very, very important for all of us to question and to maybe even to rebel rouse a little bit if we have to write our leaders and so on. So there's materials in the back. Some of you maybe got it all when you came in. There's things you can pick up later on, but just keep that in mind. So for our first speaker, Paul Hiltz, I'd like to say another special thing besides helping keep me up on my credentials, and that is that, and Pastor Mark just alluded to it, that we started an aging well program here some years ago, and I see some of the founding fathers here that are sitting in the audience that did this, and in doing this, we were up and down a little bit, and one of the top speakers that we had was Paul. He came and volunteered. However, it was right in COVID, so we had to do more of a Zoom conference, and it was about, I think it was 2021, 2020, anyway, in that era, right in the middle of COVID, that we had an update on what was going on in medicine in this area. So that was a positive. And then there's the president of the Retired Physicians Association sitting out there of Southwest Florida. That organization for retired physicians meets on a regular basis, and Paul's been one of our speakers twice now over the years, and we've really appreciated that. So thank you for doing that. And today we appreciate your speaking to us. You had a healthcare background for many, many years, and I guess the Hall of Fame had to let you go at Canton, and he came down here from there to take over in 2019 at NCH, which is now called Naples Comprehensive Health. Which is truly a good description of what they're doing. And there's a lot that can be said about what's happening there, the teaching programs, the internal medicine residency, just everything is going on with research and new affiliations. So I'm not going to steal your talk here at all, Paul, but I want to turn it over to you, and we thank you so much for coming to be our first speaker.
Thank you so much. Yeah. Can you hear me okay? There it goes. Welcome, and thank you for having me. I think probably the best way to start today is to ask our veterans, if you're a veteran, would you please stand up so we can recognize you on Veterans Day? Thank you. Thank you all for your service to this great country. Delighted to be here, and Reverend Williams, I think, started referencing some of the past healthcare policy when he referred to something called the Hill-Burton Act that was created back in the 1940s when our country said, hey, the best way to keep our country healthy is to build hospitals. So there was a big program to build hospitals all over the country through the Hill-Burton Act. Well, it turns out that didn't make us much healthier, right? So about 20 years after that, in 1965, Lyndon Johnson thought, well, the way to really keep our country healthy is through Medicare. So they established Medicare and expanded care for many, many senior citizens and people with end-stage renal disease. And it turns out that didn't get us very healthy either. It expanded a lot of costs and expanded a lot of access, but we treated sick people. And that went on until about the 1973, President Nixon said, well, the way to really do this is to create something called the HMO Act. And we'll start paying for prevention and encouraging health maintenance organizations to keep people well. And that stayed like that until, for the next 20 years, when the federal government introduced something called diagnosis-related groups. And it was supposed to incentivize hospitals and doctors not to overtreat people, but to pay doctors and hospitals a fixed cost by the diagnosis, and that was supposed to help keep us healthy until we ended up with the Affordable Care Act. And now, of course, that's the big controversy, right? We voted to reopen the government, but the whole reason that the shutdown occurred really was around Obamacare. So one of the things I would just start off with philosophically is, why do we have all this over the last 50 years or longer controversy and upset around healthcare? And to me, The main reason for that is that as a country, we have not philosophically decided, is health care a right or is it a privilege? And we won't solve that. We won't have the conversation. That's why we're beating around the edges of this thing every 10 or 15 or 20 years. Or actually, for the last 10 years, there's been a lot of debate. And I know today, so that was a little context for what we're doing. And I have one of our board members here in the audience, Lori Cowan Phillips, and I will just say, since I've been here in 6 years, we have been trying to prepare for what we thought was going to be a difficult economic climate for healthcare, because it just seemed like the perfect storm, the gathering storm was, wow, costs are going up, demand is going up, and then when COVID hit, all these, what they call deaths by despair, started accelerating, people with suicides and overdoses and the chronic disease, so many factors. And at the same time, the capacity of our national health system has been under strain from both a facility and a workforce point of view. We were trying to get out ahead of that. And so one of the themes we've been working on, and it's great to be up here with Jamie, we've tried to be a very partnering organization. So I'll just give you a little sketch of what is NCH. NCH is organized in the tax code as a 501c3 charitable organization. So there are no shareholders. It's not a for-profit company. It's organized as a nonprofit with a board of trustees that are voluntary, self-sustaining boards. So the board members, I think we've got 13 members on our board. They have 3-year terms, and after a couple of terms, they term out, and another person from the community comes on, and they become fiduciary agents, meaning they have to act like the money is theirs and not waste the money, but just that. We pay for the services we get paid for services we deliver by billing Medicare, Medicaid, and commercial insurance. And part of what we have to do to maintain that tax-free status so that we don't pay income taxes or property taxes is that we have to provide a community benefit. And we have to prove that every year that we've given a community benefit that's in excess of what the tax benefit would be. So our tax benefit of not paying property tax and income tax is in the $25–30 million range. Our community benefit is closer to the $80 million range. So we do more than twice the benefit, and we agree that we'll take care of anybody that shows up. I say all this because as a nonprofit, and I love the mission of taking care, helping people live longer, healthier, and happier lives, and we'll take care of anybody that shows up. That's different than a for-profit hospital that's owned by shareholders that are obligated to get a return for the shareholder. So those types of hospitals operate quite differently than a community-based organization like ours. One of the big things that we provide for the region here is OB services and pediatric services, which the vast majority of both of those are Medicaid recipients. So we do believe it or not, we deliver about 4,000 babies every year here in Naples. You wouldn't think that, would you? I don't think any of them are in here right now, but I'll get to that later. But so the challenge, and you'll hear similar from Jamie, when you deal with those kinds of populations and services that really don't get reimbursed all that well, then when you get to this discussion of Obamacare and the subsidies that Obamacare provides for people that are below the poverty level, that's what's at risk right now. NCH has grown a lot, I will just tell you that. You might be surprised to know that we are now over $1 billion in net revenue at NCH. $1 billion, we collect over $1 billion every year. Thank you. And we've done it by partnering with world-class organizations like the Health Network, like the Hospital for Special Surgery in New York. We're partnering with Nicholas Children's Hospital out of Miami. We're partnering with Encompass Rehab, which is the largest rehab hospital chain in America. And ProScan is our other big partnership. We think that we can accelerate quality improvements faster by partnering than we can by fighting with people. So we don't want to be fighting with everybody. We know that the resources are limited, and we don't want to duplicate things or waste money competing on things. Back to the Medicaid piece for us, we get about 8% of our revenue, so that would be roughly $80 million from customers that have bought their insurance through the exchange. When the subsidies go away, which are scheduled to go away at the end of this year, the question is how much of that $80 million will that impact us? A lot of people won't be able to afford to buy insurance, so they may become self-pay patients. Some may go to another commercial insurer, but right now, people like Jamie are really just trying to figure out what will the impact be, but there will certainly be an impact. And so what will it mean to this community? Well, again, we're going to continue to partner with people like Jamie, with the neighborhood health clinic, with other hospitals, to try to make sure that our community has access to care. And we're already looking at models of adding new primary care centers that would be urgent care centers or family practice centers, just to give people access, because Jamie and I were talking out there, when you eliminate the preventive or the primary care, it turns into expensive care because people get sicker. And that's going to be the challenge for our community. But hopefully with that attitude of partnership, we can do that. Now, how do we handle the finances right now? Well, we live in a very generous community here, thankfully. And this last year, over the last 5 years, I will say that NCH has invested capital of $1.2 billion to build things like the orthopedic hospital at our North Campus, to build the Heart and Stroke Institute downtown, to renovate the emergency departments at both places, and to expand operating rooms for interventional heart procedures. But we've also raised a lot of money. We've now raised close to $600 million over that same time, and people have stepped up when they see that we have a vision for providing great care to people and elevating the quality of care. And so one of the things that we're grateful for are the donations. The other thing we're very grateful for is we have a very large volunteer force now. Many of you have been volunteers at NCH. We have about 1,100 volunteers now, which is fantastic. And that's something that really helps ease the financial strain. And we've got other things that we're working on too, to reduce the cost of care, reduce the complications, and to reduce the readmissions. But we're going to watch as this plays out, the policy disputes, and really we're in touch with our legislators all the time, and I believe we've got sheets for you. I just had a meeting last week with Byron Donalds, who's going to be running for governor, and we're trying to get out ahead of these candidates to educate them on what's at stake. There is no perfect plan to resolve health care, and I just remember 3 decades ago I was in graduate school and the professor got up and said, hey, healthcare is 13% of the GDP. That's unsustainable. It can't go on. I think right now it's 19. It just keeps going up and up. So these kind of forums I think are very helpful. Working with people like Jamie is very helpful so that we can work together to resolve and address the changes and the proposed changes to our healthcare system. So with that, I'll sit down and turn it over to Jamie, and then I know Bob's going to introduce Jamie, and then we're going to have a discussion, I think.
I can say it from here. Thank you very much.
Thank you.
Sorry about that. I maybe confused everybody by hopping around here a little bit. But I just wanted to take this minute to introduce Jamie. I had mentioned how valuable the Senior Friendship Clinic was, and as you were just talking, Paul, it was an example of where people could be seen compared to the neighborhood clinic at the Senior Friendship Clinic, it meant seniors over age 50, so I wasn't doing any OB there. I was just doing GYN. But as we volunteered, it was over 50, and if you fit the 200 or 300 percentile level of the poverty level, you could get care. You did not have to show a stub that you were working, whereas the neighborhood clinic takes care of people who are the working poor, and I think it still is that way. So there's a little difference in what things were being helped and how they were serviced and so on. So when Jamie came along and their clinic came along, it helped us extend Senior Friendship a little bit longer. But also, your background is very, very interesting. And I was kidding him earlier, so he knows I'm going to say this, but in looking at his bio, and I think all of you had a chance to read the bios here, Jamie was in the military for 24 years and developing this career to handle, I guess, the healthcare wars or something like that. But I think how appropriate it is that it's on Veterans Day that he also had a Bronze Star and was in the military for 24 years, and I think that's very special.
Thank you. Thank you. Thank you. Thank you.
So I really don't have to say more than that because that's very important. But he also came to us as now the CEO of Healthcare Network, stopped from South Carolina, and football stories going on galore, through Florida and now Ocala, and now he's here working with us in this community. So I just wanted to make sure we introduced him, and we'll have a little slide talk here too, and then keep writing on your questions so we can get to questions after he's done. Thank you. Thank you.
Thank you. Thank you. Thank you. Thank you. Thank you. And good afternoon, everyone. Thank you for having me. I've been having the pleasure to talk to Jennifer for the last 2 weeks, every single day, about 3 times a day. What time to be here, when. And your pastor's son was born at I tell you, it's a small world. My mom worked at that hospital, Baptist Health, in Columbia, South Carolina for 20 years. So it just tells you how small the world is. Healthcare is an interesting time, and I appreciate you coming out to just kind of understand where it's, because when you walk back out of the doors, from what Paul and I will talk about, you can really educate people about how complex it is. First of all, healthcare finance is one of the most complex finances in the world. It's not like you go into Ace Hardware, you buy a nail, you pay 5 cents, the nail is there or not there. We're not sure we're going to get paid by the insurance company. And then we got to go fight to go get, because they only gave us 3 cents, but we paid 5 cents. We got to go get the remaining 2 cents back. It is a very, very complex set of finances. Now, we understand exactly what NCH does. It is a hospital system, our lifeline of saving lives in our community. Whether it's heart, stroke, orthopedic, they take care of us every day, 24/7, no matter what. What I do and what Healthcare Network does is a little different in the primary care sector. So what I'm going to do is I'm going to go through a few slides really quickly to kind of tell you what we do and what our impacts are. I think I got it. Okay, good. So federally qualified health centers is what Healthcare Network is. We were founded about 60 years ago. So in this country, community health centers were founded about 60 years ago, but it wasn't until 1992 that the president, George Bush, the son, deemed in Section 330, which is the law, that community health centers across this country would receive mandatory funding. You have mandatory funding, and that was what Healthcare Network is. We see approximately 90% low income, 20% are potentially uninsured that come into our doors, over 10 million children, 4.1 million seniors, and 500,000 veterans across the country. So this is what federally qualified health centers do across the country. There are 1,500 of us all throughout the country, Guam, Puerto Rico, and the U.S. Virgin Islands. We see about 35 million patients in the country. So I mentioned to you the 330 law that George Bush's son signed that made mandatory funding for community health centers. The discretionary funding is what we have to go in to talk to the legislatures. I was just in Tallahassee I was actually supposed to be in Tallahassee Monday and Tuesday, but I came back for Jennifer to make sure I was here today. But it's essential that we talk to our legislatures because they're the ones who are actually developing bills and developing legislatures that fund us in a way to take care of those who may not have insurance. Federally qualified health centers are a little different. So we're a little different than most nonprofits. We are a 501c3, just like NCH is. However, because we're a federal entity, our board of directors must have 12 board meetings, and it must have a quorum. So if you're on our board, you're going to probably donate a good, I'd say, 20 hours a year at our health center because you must come into our board meetings because we must have a quorum. We fall under the Department of Health and Human Services. So Dr. Oz and RFK, our secretary, is who are directly over our federally qualified health centers. The other interesting thing about us is 51% of our board of directors must be patients. So my bosses, there's 12 of them, have to be patients. They have to look like and be like our patients are. So when they come in, they're a representation. When they come and talk to my executive team, they're telling me what our entire community is seeing. We have over 60,000 patients. So they're a representation of our patients that we see day in and day out. One of the other things that's different is that our reimbursement rate from insurance companies is higher than a primary care doctor's office. So one of the reasons why you don't see any private practice pediatricians out there is because, think about this, you're a sole practitioner pediatrician seeing kids. If your reimbursement rate from Medicaid is $50, you have to see 40 kids that day. To pay your overhead, your electronic medical record, your salary, you have to work every day, probably including some Saturdays. You couldn't make it. So we see over half of this room of all children in Collier County come to our 13 facilities. So pediatrics is big. We have over 25 pediatric providers, and we work hand in hand with NCH in deliveries and Paul and his team. About a little more than a third of all babies are delivered by us in the prenatal care for the 4,000 soon-to-be moms that deliver babies at NCH. Some of the other things are we have to provide a sliding fee scale. So if you come to us and you're under that 200% federal poverty level, we must, using data of your salary and your household size, we can slide that fee all the way down to right now that our board of directors has determined is $45. So $45 will pay for a visit, labs, and x-rays for that patient who falls within that category. And it slides and goes all the way up towards our nominal fee based upon your salary and your household size. So I talked a little bit at the national level, the state level. There are 54 health centers like us throughout the state of Florida. We serve all 67 counties. So you'll find a site in all 67 counties throughout the state of Florida, providing over 750 locations, 100 school-based locations. We have one school-based location here that I'll talk about in Collier County as well. And we serve almost 2 million people in the state of Florida. Healthcare Network. Now we're talking about Collier County. Healthcare Network has been in Collier County for close to right at 48 years. We started out as an agriculture farm worker community health center in Immokalee. And for those of you who don't know the level of farming that goes on out there, 94% of all tomatoes that you eat in this country comes from Immokalee. Yes, the farmers come in on visas, they work there in Immokalee, and they travel in this circle. Their home is Immokalee, and they travel in this circle up through South Carolina where the Lay's potato chips are grown. They come around through Tallahassee, a little bit through the Panhandle, and then they come back home based upon the season. But Immokalee is the home for a significant amount of agriculture farm workers. That's where we were founded to provide health care for them. And over the years, we saw pockets where there was no health care. And we moved west, closer to Naples, and closer to this direction. Our mission is to provide quality health care to anyone, no matter your ability to pay. And we provide a host of services that you see listed. Some of our newest services are optometry and infusions. So as you see the little blue dots, that's our 13 sites located. A lot of our locations are in collaboration with NCH, but I will show you the 2 red areas that you see. When I talked about an underserved area, the one that's in Orange Tree was an area that has 60,000 people from Collier County that live there. There's not one doctor, there's not one pediatrician. There's one dentist that was in the Publix shopping center. If you know where that's located on that little curve, that was it. And I went to Senator Pasadoma and I went to Representative Mello, and I said, look, we need to put a primary care office right here that feeds to the North NCH Hospital. And the community overwhelmingly came together to fund this building. I'll show you a picture of it, but it's a 20,000 square foot building that's being built there that we expect to open in February. It was funded by state appropriations, philanthropy, county, city, CDBG block grants from our county commissioners, as well as federal funding and grants. So this was a community effort to fulfill an area that we did not have health care. The next area that you see coming soon is an area that Paul's team will be opening or has already opened a site providing health care for an area that did not have health care. There are over 8,000 children in the Ave Maria community, with about doubling that, almost 20,000 people, but there was no doctor's offices there. So Paul's team opened an urgent care clinic that we will be working with them towards the end of November to provide pediatric care together in that same facility. And as NCH expands in Ave Maria, we'll play a crucial role with prenatal care and seeing all of the children that are in that community. So who are some of our patients? Under last year's data, about 55,000 patients. This year, we're already on track to have about 62,000 patients. We have over 200,000 visits. I will tell you, just like NCH's data, 8% are in the affordable care market. About 10% of our patients are in the marketplace. So 10% of our patients come to us today that receive the ACA and log on. Now think about this. You live in Florida. Florida has some of the most small businesses in the entire country. Most of the small businesses, if you do not have more than 50 people, go into the ACA. They go into the computer and they find an insurance plan, whether it's high deductible or not, and they pay for it. And once you put in your household and your income, the federal government says, okay, I'll give you $50 towards that, or I'll give you $100 towards that insurance plan. So now your premiums are lowered to maybe $150. Well, I could probably afford that for me and my family. You're able to go to work, provide health insurance for you and your family. When that subsidy ends, the piece that the federal government was giving to that will stop. That insurance plan will either double or potentially triple, which means that one person that was paying $150 to $200 is now going to be paying about $600 or $700. Some letters have already gone out to people telling them this is what your new plan is going to cost. By law, I think they have to do it in 30 or 45 days, something like that. So the insurance companies are already sending them letters saying, hey, your plan is going to be like this. And so that's what's causing some of the things that Paul was talking about, of the uproar. How am I going to pay for that insurance? I'm going to probably stop paying, not have insurance, come into our facility, and come into Paul's ER. That's where we're going to all feel some of the financial strain. Some other data on the type of patients that we see. Obviously, a lot of uninsured. We do see patients who are homeless as well, but the majority of our patients do come into us, do have either Medicaid, Medicare, or are with other insurance plans. So we could not sustain ourselves if all we saw were people who did not have insurance. So we see people who have insurance, Medicare, Medicaid, as well as our regular payers. But remember what makes us different. Our reimbursement rate is slightly higher to help offset those who do not have insurance. So what's some of our challenges? Well, you all know workforce. You've been probably hearing workforce, 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 and you see all the apartment complexes that the county commissions have been approving to build for workforce housing. That is always going to be a challenge here in Naples. We know the differences in what people pay from one end of the perspective to the other end. So that's always going to be a challenge, but there are things that both NCH are doing and we're doing to help alleviate that. Rising operational costs is what we talked about a little bit earlier. Our insurance, what we pay on a visit, what we actually provide for a patient compared to what the insurance gives us, there's a big difference in what that is. And you can only do that for so long before we start to have financial strain placed on the entire market. Behavioral health demands. For every person who lives in Collier County, there's about 350, 360,000 people that live here. There's only one behavioral health therapist for 8,000 people. That's how, we're one of the top in the entire country of the differences of not having behavioral health counselors. So that's another area that's obviously a challenge. And some of the other challenges are just things that we deal with our outreach team and with Paul's volunteers, in taking care of people, whether it's transporting them over to Nicholas Hospital in Miami, whether it's providing food through food banks like we were able to do this past weekend. It's all the social things that we do provide outside of just taking care of patients. So some of the things that we're doing to fix that, I talked to you about the Orange Tree location, the building that you'll see. On the your right is the new Orange Tree building. It will be fully operational in the March-April timeframe, and we will provide all of our services at that location. The other building is a building in collaboration with NCH. NCH owned this particular building in Immokalee, and they brought us in to work in that building. For 30 years, we worked in that building. That building is 35 years, like a bomb shelter. We're doing a $5 million renovation to that building. It had 18 exam rooms. It now will have 31 exam rooms. So we're expanding services there to be able to take care of the folks that live in Immokalee. There's about 25 to 26,000 people who live in Immokalee. You'd be surprised at really how large Immokalee is. Some of the other things that we're doing to take care of these challenges is we're placing healthcare where the problems could potentially be. This is Manatee Middle School. Manatee Middle School and Manatee Elementary School and the high school are non-bus communities. It's literally like a school in this community that everyone walks to. Everyone lives around the school and they walk to school. So what we did is, in collaboration with NCF, Naples Children Foundation, who does the Wine Festival, funded us to put a school-based health center in Manatee. So we have one of our health centers in the school. And I was talking to Dr. Riccadelli earlier this week, Monday, as a matter of fact, about what that impact was. Of all her schools in Collier County, and she's the superintendent, she said this was the only school that 100% of the children were able to come to school day one without a health care issue. So we see that this could make an impact. And this school also was dealing with some behavioral health challenges. They even had a suicide. So when we placed this community health center in there, we were able to alleviate some of their behavioral health challenges. Pediatric dental residency and family medicine residency. NCH, and I don't think Paul Amami mentioned this, has an internal medicine residency. So when you take these 3 residency programs, when these students come through these programs, we always are going to siphon off 1 or 2 to stay right here in our community. I mean, who wouldn't want to stay here? So when these pediatric dental residencies, currently we have 7 that will be going through the program in June. We already identified 2 of them that we know we're going to really go after hard to make sure they stay in our community. Our family medicine residency program will be starting in June and July as well. And so it is imperative that we hold on to some of these residents. In the internal medicine from NCH, they stay on to be Paul's internal medicine hospitalist that actually runs the day-to-day operations of the hospital. So we work closely with these residency programs to try to keep the workforce challenges in these areas at bay. And finally, mobile units. I arrived in July of 2022. We had 2 mobile units. One does sealants on kids in our schools throughout Collier County. The other one was at the end of life, and then Ian hit. And this community was one of the communities that was asking us, can we bring a mobile unit in, set it up, and provide tetanus shots to everyone who were working in their houses. And I remember going out to one of these pop-up locations where we didn't have any mobile units, so we just popped up a tent. People were walking up to us with scratches all over their bodies, walking through God knows what. And we were able to provide services to take care of those wounds as well as tetanus shots. And I said at that point we were going to get more mobile units to not only provide emergency preparedness services, but also go to areas in our county where we don't have health care. For example, we are I think the #1 largest county by land mass in the state of Florida. To get from here to Everglades City, it's going to take a minute. So we take our mobile unit twice a month and we park it. It has the ability to sit there for about a week without going anywhere with the generators, the fuel, the water supplies, and provide services there twice a month, as well as Chokoloskee and some of the further areas in our community when we don't have access to health care. So this completes kind of the information part. I know we're going to get many questions philosophically. You know, I can't tell you how much, philosophically what Paul said about in this country, is it a privilege or is it, a right? Think about your driver's license. Your driver's license is a privilege. I mean, you don't have insurance on your driver's license, you don't drive, or you can get a ticket or you can go to jail because that's a privilege. Health insurance, again, is different and a lot more complex. And because of that, I believe that is truly what does cause a lot of our challenges. Being a retired military guy, I have TRICARE. And TRICARE is more still preventative. It's more designed to prevent you from going into the hospital. Whereas Medicare, of course, is a little different because it's not necessarily going to pay for those services as we're entering in a stage of our life that you don't need all these different type of things from a preventative standpoint. So you hear Medicare for life, you hear all these different things. I'm glad I'm not necessarily in their footsteps because it's definitely a challenge. So I think we're going to be opening it up to conversations and questions. Thank you. Thank you. This is where the fun begins.
Thank you very much, both of you. It was excellent. We're hoping that questions will come rolling on in here, and if anybody has any, or make sure you bring them up, we can do it. We're trying to do it. Write it if you could. Just that would make it a little bit easier on people and so on. Good. We'll grab. Yeah. Okay, so we picked up one. We'll keep picking up more. I think we have helpers out there to get these questions. So this question is, what is the current relationship between NCH and the Northwestern Medicine, that comment that you made, Paul?
Sure. So we have a nice relationship with Northwestern Medicine. We right now have entered into an agreement, a professional services agreement with them to help manage our oncology division. We are looking for an oncology leader, a physician leader that Northwestern is helping us with. They helped us renovate and design our infusion center where chemotherapy was delivered. And over time, over the next year and a half, Northwestern will become the sponsoring organization for our residency program. So we have 80 residents and fellows right now at downtown Baker. Mayo Clinic was the sponsoring organization, but Mayo is really getting out of those kind of relationships. So we've entered one with Northwestern, and then finally, they will be bringing their clinical trials for oncology to Naples, which will be a big help for us as we expand our cancer services.
Good. Thank you very, very much. I think this might apply maybe more to Paul, but there's a question here about the original subsidies that might have been going on when the Affordable Health Care Act came through, and are those enhanced, or were they going to be? And of course, now we're in another crisis with that. This is maybe outdated by minutes here, but
So the enhanced subsidies came about during COVID, and that's the piece that's going away at the end of this year. So it's been, as Jamie said, very complicated, the financing for all this stuff. But that's the real issue here.
okay, good. Okay, this has the question here is, what's the role of Big Pharma, and what does it play in the whole situation here with healthcare services and so on?
Go ahead.
Big Pharma.
Okay, there's a tone there, okay.
Yeah, Big Pharma is very interesting because when you go into other parts of the world, Big Pharma is not necessarily Big Pharma. The cost of medications continue to soar, especially in our country. And so our health center has a program that's called 340B, and it's just as complex as anything, but it allows us to purchase our medications at the cost of what the manufacturers make it. I'll give you an example of a diabetes 30-day injection or medication. It costs a manufacturer about 8 cents to make one 30-day supply, but yet they charge a copay. The insurance company charges a copay of about $150, and then the medication is paid out to the doctor's office or to that paid out to the entity at about $300 to $400 for that medication. Remember, the manufacturer, it only costs about 8 cents to make it. So these are all the pieces that's in between Big Pharma, but right now there is some legislation that is being looked at to try to bring these costs in that are more comparable to what other countries pay for medications. So more information to follow on that, but I think that obviously the medications that Paul sees with cancer medications is a totally different ball field, so
You know what, that's an interesting question, but one thing, we don't know the answer yet, but won't it be interesting to watch what just happened last week when the federal government is making available to people with diabetes and obesity, the GLP drugs, the Wegovy's. Huge change in thought there, but the thought is those drugs, if they reduce obesity, all the complications that come with obesity, the theory is that should bring the overall cost of care down for those populations of people, because they're now even finding that the GLP drugs have positive impact on your cardiovascular system as well. So it's a work in progress, but it'll be fun to watch it.
Yeah.
Thank you very, very much. We've got kind of a bundled question here because one is in behavioral health, the other is family doctors and so on. What are you thinking about the shortage? I was really impressed to see the facilities getting more clinic examining rooms and things like that. How about recruiting of doctors in all these areas, behavioral health and family and general health? How's that?
I'll start off with the primary care, and I'll pass it to Paul, who has much more of a specialist recruitment. We've not had as many challenges that people would think when it comes to family medicine, pediatrics, and or some of your preventative care specialty type doctors. I think that our salaries are competitive, and so what ends up happening, we have over 100 providers, but they're mostly still in the area of primary care. We do have one infectious disease doctor that assists with our infusions of antibiotics and some low-grade biologics. However, when you start talking about oncology and those type of drugs, we, of course, collaborate and ensure that Paul and his team at NCH has those. But I will tell you, behavioral health is a challenge, but we work very closely with FGCU and Florida State University with our psychology program and the interns of MSWs and licensed clinical social workers. And so we do receive those interns, and we fight vigorously to keep them here in our community when they complete those fellowships and internships. So.
I've got two comments on that. The first is on these high-end specialists. We've been really pleased with our success. We started in the heart and stroke, recruiting a leader from Mass General Brigham, Dr. Robert Cabedu. He has then turned around and recruited some super high specialists from Cleveland Clinic, Johns Hopkins, Mayo, and this year will become the largest open heart program in the state of Florida, so people are responding to that. On the orthopedic side, we partnered with HSS, which is the #1 orthopedic hospital in the country, and again, that hospital is blowing our projections out of the water, how busy that thing has gotten. But finally, we are excited that this week, the county commissioners approved helping with a grant to fund a medical school which is coming to Collier County. We intend to work very closely with, it's an osteopathic medical school that'll produce about 160 doctors each year. The first class will enroll in, I think, 2.5 years, but that supply of doctors for this region, we think, is really going to be a big deal.
And those doctors will be rotating through our facilities, our 13 sites. And so when you add what NCH is doing and what we're doing, I think workforce, we're going to be okay, but it's more of the frontline staff that we constantly have challenges. Paul will take about 10 of my employees a week. No, I'm just kidding.
Yeah.
Just kidding. And then I'll take them right back, and we just go back and forth. But no, the front, in all my years of doing healthcare administration, whether it was in the Army or out, I never had an issue with the medical assistant or the LPN. It was always getting the doctor. Now we have challenges with who's going to take care of the doctors, who's working the front desk to process the patient. That has been a nightmare challenge. And you have an entity the size of NCH, Arthrex, it's a challenge. There are over 65,000 people who drive into Naples and Collier County every single day because they can't afford to live here.
Thank you both, because that's a very complicated concern. But I was very impressed that the internship or the internist residency program got started just as I was kind of winding down, and it's grown. I understand the demand is overwhelming to get into it, and that's a real honor. And then when I was leaving with the senior friendship, you were just starting to bring in nurse training and things like that, and now it sounds like you're getting into the medical aspects of this new medical school possibly coming along. It's been rumored for a while, but it looks like it's pretty close. I think there's a bunch of old professors out here that want to come back and teach, but anyway.
I'm going to take a privilege of the chair and just ask a question, because you were leading into a question I've had for quite a while. Do you see employment issues in trying to staff for what I would consider the lower end of the healthcare team? I'm thinking of aides. I'm thinking of the people I witnessed when my husband was in the hospital, who were from Jamaica or from Haiti or some other place, and were providing wonderful service. Are there issues now that are more of a challenge for you?
Well, first thing people ask me a lot of times, hey, has all the ICE raids and the immigration enforcement had a big impact on NCH? We employ 5,000 people. We've had none of our employees have been directly affected by ICE and the immigration enforcement. We've had about 24 employees of contractors that work at NCH who were here on an H-1B visa that did have to to leave because it had expired or something. So that's, I just say that. The second thing is, and I think Jamie's probably doing the same thing, is that I think all industries, but healthcare for sure, is now dipping down into high schools to get kids interested in healthcare. And so we get part-time workers and volunteers to get them into the pipeline to become employees.
That's good. I always thought, related to that, I always thought the military, you know, you get the people that had good training in a war situation and so on, but they had to start from ground zero, literally, to get to be a physician or whatever. And I understand they're working on giving some credit and moving them along a little faster with the pre-med and eventually medical school to at least have that training count for something.
Absolutely. And, you know, to Paul's point, we're one of the larger employees in Immokalee, and so we've been a little closer at what it looks like and feels like from some of the ICE raids. Our employees, we have about 500 employees, and of those 500, none of them, it impacted them from a standpoint of them not being here on a valid H-1B visa. But their family members and their friends, their neighbors have been drastically impacted, and sometimes you just don't know what people are going through. And they have obviously gone through some challenges from what other people have seen. If you think about this, Haitians are here on asylum, legal asylum, because of all the atrocities that they've suffered in their country. And their asylum ends, I believe, December 31st. That's going to be interesting because a lot of them work in our nursing facilities. A lot of them, you know, we're multicultural organizations. Our people don't just answer the phone and speak Spanish and English. They speak Haitian, French, Spanish, English. And so because we're multicultural, it's going to be really interesting in how the dynamics are of the Haitian population, more importantly, as that asylum date does come up. We have had some Venezuelan employees who were here on visas, and the administration did end that visa abruptly, and so they either had to go or leave based upon their visa date. So it's ongoing. It's just something else is added into the complexities of healthcare that we do and see day in and day out.
And we should try and fight for some help here, I think. That's one of the political things we're talking about. Another question that came along was about Medicare cuts, and will this affect the coding, so therefore certain procedures won't maybe be covered, or difficulty getting the surgery done because of expenses with Medicare cuts?
That's an ongoing thing we're looking at. One of the interesting things, there's a ton of changes going on in the Medicare coding and which procedures will be covered in a hospital versus Medicare trying to move a lot of the procedures out of a hospital into lower cost settings. But one of the things that we're battling, you read and hear a lot about AI, artificial intelligence. The insurance companies are now have an interesting thing going on with AI. They've got AI-generated letters denying coverage or requesting more information about a procedure, which has just tangled up the health system, responding back to these auto-generated letters on that topic.
Yeah, you know, that's a crazy one in that in the state of Minnesota anyway, where we were quite involved with political fights on the HMOs, because we called it the land of 10,000 lakes or 10,000 HMOs, but that's another story. We had to really fight hard because we were getting denials on surgical things from some low-lying secretary who didn't even pronounce the name of the procedure correctly or had no idea what it was. We finally got it up to a level that you had to have a specialist of that same level of what you were reviewing to turn it down or to accept it, and that seemed to be an important thing. We had one other good question, I think it's really for Jamie, and that is, will the pediatricians or family doctors in your area and so on be able to promote vaccines? Is there any holding back, or what's going on from the federal, national level on this?
Yeah, well, you know, we live in the great state of Florida when it comes to vaccines. So this is a really interesting topic because Collier County has a high amount of non-vaxxers for their children, but we have the largest amount of vaccinated kids. Isn't that interesting?
Yeah.
That is because they're listening to our pediatricians. Our pediatricians are telling them, hey, look, there's a reason why smallpox has not infected, that has basically been eradicated out of this country. There's a reason why mumps, measles, and rubella has not been in this country for almost 50 years. And so well, I don't really want them and I don't believe in them, but yes, go ahead and take care of my child. So, and that extends to Collier County is #1 healthiest county in the state of Florida. This is a reason why. The collaboration of how Healthcare Network, NCH, philanthropy comes together and is able to tackle our healthcare challenges when we see them. So, to answer your question, I believe that we do the right thing and we do the smart thing. That also extends to the fluoride in the water. Obviously, we knew that that was somewhat of a challenge. However, for those parents that still want their children to have fluoride on their teeth, our pediatricians are able to do that in their visit, or our dentist. So it's something that we're still able to provide if a parent or the patient decides that that's what they would like.
That's wonderful to hear. I think this might be for you again, Jamie, but it's an interesting question, and that is Health and Human Services only for nonprofit? How does it participate or work as a partner in the for-profit area? For Paul, I'm sorry.
Yeah.
For Paul, okay.
So Medicare, Health and Human Services, Medicare works with for-profits too. In fact, this is one of the maybe flaws in the system, is that they pay on traditional Medicare on a DRG, they pay on the diagnosis, and it doesn't matter, there's not really a lot of you can go get a much higher level of care in one hospital, but you're paid exactly the same as the other hospital. It all depends on your diagnosis. So that's a little bit of a flaw in the system. They're trying to change that by having quality incentives, but they really haven't caught up to. So a specific example of that is we've spent a tremendous amount of money recruiting in high-end cardiac specialists who specialize in minimally invasive procedures. Minimally invasive procedures are important for older people because you can actually have the procedure where you maybe couldn't survive the open procedure, but we're paid at the same rate then as the old traditional way. So we think that'll catch up over time, and we're willing to invest the money in it because it seems to be the right way to do it.
We have another one about kind of bridging the gaps here, and see if I get this correct, but it's the idea about how can local community boards or organizations who focus on senior care work with NCH and healthcare networks and so on to bridge the gaps of where there's a problem and gaps in care.
I'll start with this one. You know, I have a dinner at the Senior Baker Center tomorrow night. And I'll tell you, there are places to where Healthcare Network provides its services for seniors, and it directly ties into where and what patients that NCH sees. So there are multiple places. The new Echos property that was just recently built is for seniors who, affordable housing for seniors. We have a small clinic within that new, it's somewhat of like an apartment complex, but it's really, really nice. And so we have a health center within that new facility to provide health care for those seniors who live there. And so I'd like to say that we work very closely with all of our healthcare counterparts, including NCH, when it comes to our seniors.
Great, super. I think we've gone through all of our questions. I was worried we wouldn't have enough questions, and I was a little worried would they be any good. Number one, you took care of all my worries, so you did a great job. But let's give a hand to our wonderful speakers. Thank you.
Well, thanks, Paul.
Nice job.
Thank you.